Okay, I'm sorry. Please, please kindly introduce yourself by writing your name, email address, and your workplace on the chat box. So we have from Senegal, we have from Martini, from Germany, Cameroon, so we have participation from many countries, and as you identify yourself on the chat box, we will just first now go to the next session. So now, may I now welcome Dr. Samuel Wakusa, OI Sub-Regional Representation for Eastern Africa, Nairobi, Kenya, to give a welcoming remarks.
Sam is muted.
Yeah, Sam.
You're muted, Sam.
It's pre-recorded, so I can do it again, but it's pre-recorded.
Okay,
Thank you.
Please, can you unmute us, please?
Bas?
No, daga can ne ba. This from there.
Hello, can I just read the speech because the recorded one isn't working?
Yeah.
Okay. Yeah, dear colleagues, partners, ladies and gentlemen, I welcome you on behalf of the Regional Africa Tripartite to this time is in French. Yesterday, some of you may have had the opportunity to attend the virtual United Against Rabies Forum meeting launch. As you know, dog-mediated human rabies is a deadly disease whose control and eradication is readily feasible, but faces some challenges. For this reason, that the Tripartite and its partners developed the global framework for elimination of dog-mediated human rabies with a focus of achieving this by 2030. This year's theme is to end rabies, collaborate and vaccinate. We would have liked to organize a face-to-face meeting, but because of the COVID situation, we all understand this was not possible. Including the experiences of successful mass dog vaccination campaigns from selected African countries, both from Southern, Western, and Eastern Africa, experience with using oral rabies vaccines, engagement of NGOs and partners towards rabies elimination program, rabies diagnostic techniques and case management and surveillance in humans and animals. Will also be appraised on the new OI standards to support global elimination. The UR initiatives and progress and WHO achievement on rabies elimination in Africa. There will also be a presentation on design of effective mass dog vaccination campaigns using different tools. And you will also have a country experience from Tanzania on how One Health integrated rabies case bite management approaches have been conducted. And lastly, you'll have a World Rabies Day 2020 continuous rabies awareness during COVID-19 pandemic. There'll be a presentation on that. I once more welcome you and hope that this will spur our effort to a united front to eliminate dog-related rabies by 2030. I thank you.
Thank you, Dr. Sam, for your clear welcome remarks on the importance of rabies elimination program. We have covered all the topics that will be discussed during the 2 days webinar session. Thank you very much. Now we are going to start the presentation and discussion session. And I would like to request Alexander to kindly introduce yourself to the participants.
Thank you. Thank you. I'm Alessandro Ripani. I'm working as a veterinarian at the OASAB regional representation for North Africa since 2014. I'm very happy today to be with you and share this this webinar that will have a very interesting presentation, and I hope that will be one of the outcomes will be to create the synergies and to move forward towards this objective. So thank you, Tenzin, and over to you for the first presenter.
Okay, thank you, Alessandro. We have 4 country presentation by rabies focal person from Kenya, Namibia, Nigeria, and Sudan, and they will share their mass dog vaccination campaign experiences and some of the challenges. If all the participants have questions to the presenters, you are requested to post your questions on the chat box, and at the end of the 4 presentation, we'll give an opportunity to the presenters to respond to your questions. Now I would like to invite Dr. Matthew Muturi from Kenya. He is a field epidemiologist working for the Ministry of Agriculture, Livestock and Fisheries in Kenya. He currently heads the Zoonotic Disease Unit, a One Health coordination office formed between Kenya Ministry of Health and Livestock Health. He has served as a One Health expert consultant for the World Health Organization as a joint external evaluation and bridging workshop experts, and OI's One Health program in some of the Eastern and Southern African countries. The floor is to you, Dr. Muturi.
Matthew Muturi from the Kenya Directorate of Veterinary Services, and today I'll be sharing lessons from successful mass dog vaccination campaigns in the country. Kenya is currently implementing a strategic plan for the elimination of human rabies in the country. The strategic plan has 5 main pillars, or the 5 main drivers, but mass dog vaccination is the main anchor of this particular strategy. The other strategies are prompt provision of PEP, post-exposure prophylaxis, to expose individuals, public health education and awareness on rabies, both at community and decision maker level, enhance surveillance for rabies in humans and animals to improve data quality for decision making, and advocacy, communication, and social mobilization towards rabies control. This strategy is implemented using a stepwise approach to rabies elimination. Kenya is currently in stage 3, but we are still implementing some of the activities that were supposed to be carried out in stage 2. However, today, as I mentioned, the premise of my talk will be on lessons learned from mass dog vaccination campaigns in the country. So one of the most important lessons, in our opinion, is the need to identify and characterize your target population or your target audience. Who are you focusing on when you're planning some of these vaccination campaigns? So, for example, in Kenya, dogs are primarily under the care of young boys to their late teens. It's almost a cultural affair to own a dog as a young boy in parts of the country, and planning and execution of mass dog vaccination campaigns must consider the behavior and practices of this particular age group. For example, one of the things we've learned that works very well in Kenya is the need to plan vaccination campaigns during school holidays, where a lot of these young people are available to bring their dogs to vaccination centers. Also, they need to make sure you're using communication channels that appeal or that will reach this particular age group. For example, colorful posters and vehicle-mounted public address systems, as opposed to channels that might be quite expensive and will not really reach this particular audience. For example, television adverts. And so what we've learned is the importance of, for example, doing mini surveys just to identify which is the main or which is the best mode of communication. In Kenya, for example, we've learned that vehicles mounted with public address systems that move around areas where we are planning vaccination campaigns works best. And also, you also need to make sure that the areas you choose as vaccination points are areas that can be easily accessed by young people. And so, for example, in Kenya, we use schools as vaccination centers because they are sort of able to relate to some of these areas, and because these are schools they go to, they are very easily accessible by these young people. Second lesson we've learned is that vaccination campaigns should be and must be data-driven. A lot of the times when we are doing dog vaccination campaigns, especially in most rural regions, we really don't know what is the correct or valid dog population. And so it's quite important to do, for example, dog ecology studies to estimate the population of dogs, as this is very important in estimating vaccination coverage and also identifying missed areas after campaigns. Currently, there are multiple free mobile phone apps that can help to estimate the vaccination coverage after a campaign, and so we really encourage local governments who are doing these campaigns in Kenya to use some of these mobile phone apps. And also, it's quite important, even before the start of the campaign, to make sure that you have designed tools that can be used to collect or enhance data on dog ecology and rabies burden. For example, what happens in Kenya is when we have mass dog vaccination campaigns, we use that opportunity to collect data, for example, on dog ecology. Somebody will bring their dog and we ask them questions on dog ownership and practices that they have with their dogs. We also take this as an opportunity to collect the surveillance information on dog bites. For example, you ask, in your household, how many people have been victims of a dog bite in the last 6 months. And what we've realized is ultimately this helps in improving data quality. Also, it's important to, and that's why I put this point, to make sure that we sort of keep up with the current scientific evidence, especially in endemic areas. For example, it has been shown that it's okay to vaccinate dogs under 3 months, as opposed to the traditional knowledge that only dogs above 3 months can be vaccinated, because in areas, for example, we are doing annual vaccination. Missing some of these dogs will mean that they have, for example, a whole year, they lose the opportunity to get vaccinated. So it's important to keep in touch with the current scientific evidence and make sure our campaigns are done. The other very important point is the need to innovate to keep vaccination costs low. For example, one thing we've learned in Kenya is having 2 people at a vaccination point is adequate, and you don't have to have 2 technical officers. For example, you don't have to have 2 veterinarians man a post. You can have 1 veterinarian or animal health worker, and you have a non-technical person to help in data in data keeping or keeping records. Also, the other lesson that is very important is on the need for bulk procurement of vaccine and using facilities like the OI vaccine bank to keep vaccination cost low, and also on the bulk procurement of supplies. For example, printing vaccination cards. The more you print, the cheaper it is, and this is true for many other supplies. And also in Kenya, for example, we use public facilities as vaccination centers. So these are free areas that we do not have to pay to access. And so the advantage, for example, for going to a school is you get desks, you get chairs, and all these things you get free of charge, as opposed to working in areas where you have to hire some of these particular facilities. And this is an example of data cost data from vaccination of 45,000 dogs. And the math is as simple as the more dogs you vaccinate, the lower your costs are. So intense campaigns over a short period, as opposed to small campaigns over multiple times in a certain period. The other lesson we've learned is mass dog vaccinations are more successful with involvement and commitment of local and national governments. So there's need for strong advocacy among political leadership to make sure that we get the funding that is required. There's also need to make sure that a lot of these plans to eliminate rabies and do, for example, these vaccination campaigns are done. These plans are done with the local leaders. For example, the local political leaders, elders in villages and such, so that you make sure you get as much support as possible, and also making sure there's multi-sector planning when you're doing mass dog vaccination campaigns. For example, involvement of the education sector to make sure that children are informed before they go for their school holidays, to make sure that you have access to some of these school facilities is quite important. And the other very important point is to adapt to varying dynamics of different regions. For example, in certain communities, they observe Saturdays as a holiday. Others observe Sundays, and others observe, for example, Muslims, Fridays as their holidays. And so you have to be sensitive to the beliefs and practices of the local communities. So do not plan, for example, a vaccination campaign on Sunday when people are going to church, on Saturday where certain denominations are also going to church, or on Fridays where Muslims are going to their mosques. And also to consider the fact that different regions will have different dynamics. For example, fixed post-vaccination campaigns work best in densely populated areas, and the opposite is true for sparsely populated areas. So lastly, I wanted to finish off with the general rules for successful mass dog vaccinations. So make sure that these campaigns are free or the lowest cost to the dog owner. Good publicity is the anchor of any dog vaccination campaign. Make sure that you have good data collection tools, as this is key. And make sure that the local and national governments must be fully involved in funding. I believe that is my slide, and I thank you for your time and listening to me, and thank you for the opportunity. Thank you.
Thank you, Dr. Matthew, for sharing various lessons learned while organizing mass dog vaccinations while planning and implementing mass dog vaccination campaign. We will get back to you later to respond to some of the questions from the audience.
Thank you. Now we move to the second presentation, and I'm pleased to introduce Dr. Runa Atingo. Dr. Atingo is a veterinarian responsible to oversee the planning and implementation of animal health management, disease control programs, and disease surveillance in northern communal area of Namibia. Since 2015, she has been the national coordinator for the implementation of Namibia rabies control strategy, and has been responsible for coordinating planning and operationalization of mass animal health code related to stray dog population control. She will share the mass dog vaccination campaign experiences in Namibia. Over to you, Dr. Atingo.
Good afternoon, everyone, depending on where you are in this global village or forest. A warm welcome to you all to my presentation, and thank you for the beautiful introduction. I am very grateful for this opportunity to share the Namibian experience of a successful mass dog vaccination campaign with the aim to eliminate dog-mediated human rabies. This program, through a project, is a realization of our national control strategy which is implemented with the support from our international partners, the OIE, the federal government of Germany, and the FLI, which is an institute in Germany. For those who don't know where is Namibia, just to give you a little bit background of my beautiful Namibia, which is one of the largest countries in the world in terms of area, with a less population, just over 2.5 million people, with a population density of 2.6 person living per square kilometer. We are ethnically diverse nation with 11 ethnic groups, speaking 22 different languages, and we border from north to south with Angola, Zambia, Zimbabwe, Botswana, and South Africa. And the west is South Africa for ecotourism destination. When it comes to rabies in animals in Namibia, data from 2011 to 2017, it shows that there are two forms of rabies documented in Namibia: the canine, which is more prevalent in communal areas, as depicted in these two maps here, which shows the rabies surveillance data. And the wildlife, which is the sylvatic one, is more prevalent in the southern as well as the central part of the country, with the kudus being the most affected species as shown in the map. When it comes to human rabies, there seems to be a clear correlation with regards to canine rabies cases as well as human rabies, of which the data from the surveillance from 2011 to 2017 shows that both are more prevalent in the northern communal areas regions. However, Kavango regions, as shown in the graph on the right, shows that there are more human cases than canine cases which have been reported, and this shows an element of under-reporting. With regards to age, children under the age of 14 are more vulnerable. However, human rabies cases have also been reported in adults which are under the age of 20. It is worth mentioning that rabies is a notifiable disease in Namibia, both in human and animals, as catered by our policy. However, there has been challenges on how to successfully control the disease. Hence, as a country, we developed a national control strategy, which was officially endorsed by the Honorable Minister of Agriculture in March 2015. And the strategy is informed by the multi-sectoral One Health approach, and the drivers of the strategy are the Ministry of Agriculture, Ministry of Health, as well as the Veterinary Association of Namibia and other role players in the strategy. Within the strategy, we identified other stakeholders with the aim of them also becoming role players by promoting the strategy, advocating for the strategy in order to mobilize resources, mobilize the communities in order to buy in the strategy. And most of them, they have got a direct influence to the communities, and as such, they are very, very important. The project has been co-financed by the federal government of Germany with technical support from the OIE as well as the FLI Institute, and has been implemented in phases, with the pilot phase done in Oshana region, which was officially launched in April 2016 as indicated in the picture here, and Oshana is shown in this map highlighted red. And thereafter, the campaign commenced in 2016, and Oshana was chosen simply because it's one of the hotspot area when it comes to both canine and the human rabies cases, as per official surveillance data. And the campaign covered the whole region over a period of 6 weeks, with the second round, which was done 6 months apart. Capacity building is one of the activities identified as very crucial in implementing mass dog vaccination campaign, and it covers training of participants or participating staff in the campaign, and they have to be capacitated both theoretical and practical aspects of rabies and as a disease, and also on how to conduct a mass dog vaccination campaign. This also related to passing on the correct message of rabies as a disease, the animal handling aspect, the data collection aspect, and on how to approach the dog owners without violating their cultural as well as their social values. Rabies awareness and education is another critical activities or component of a successful campaign, and school-based awareness education was very crucial because of two things that we have observed in Namibia. Firstly, children being the most vulnerable and being the victim of dog bites, and secondly, the history have shown that children, they have been participating in rabies programs in the past by bringing dogs to vaccination. Hence, by educating them, it will also go a long way, and they also have to serve as good ambassadors as well as good educators, and they can be used as drivers to spread the rabies message to their fellow children as well as their parents and their community at large. Education was very inclusive, catering every ethnicity or ethnical group, even the most remote and the most vulnerable and the previous disadvantaged and neglected communities in Namibia. And we have utilized all other platforms such as television. We have held radio talks. We have done newspaper publications for a wider visibility of the project in the country and in the region. The most crucial element of a successful mass dog vaccination campaign is resource mobilization and logistics deployment and arrangement in your campaign. And in Namibia, we have employed what we call the approved, pre-approved budget for the campaign, as well as taking inventory of infrastructure such as the cold chain facilities, the laboratories, as well as transport, just to make sure that before you deploy your vaccine to the regions, the cold chain in other regions are well functioning, the transport to take vaccine to the communities is available and in good conditions. Other equipment and material is the PEP. As we have noticed that during campaign, the incidence of dog bite, they increase during handling of dogs during campaign time. And in conjunction with the Ministry of Health, we have to make sure that the PEP is available at the facilities which communities can access. And other equipment, the handling, your vaccine, as well as the megaphones. In the pilot, megaphones have shown that teams which were using megaphones are likely to vaccinate more dogs than teams which are not using the megaphone. People become so curious to hear of the message which is actually coming from there. Your cooler boxes are very crucial in maintaining your cold chain in the field. The mass dog vaccination campaign over the past years has been implemented through the vaccinating at crash pens, which are actually meant for vaccinating cattle against priority diseases such as CPCP and FMD. However, during our program or the strategy implementation, we have implemented what we call targeted campaign, where we employed the central point as well as house-to-house vaccinations, especially in urban areas. And also vaccination were also conducted during school holidays, simply because the kids are the most one bringing dogs to the vaccination point. And to them, such event also serve as a social event where they come to interact with one another and get to admire others' dogs. The disadvantage of using vaccination campaign at crash pen alone is that it's also the distance associated with how these vaccination crash pens are allocated. And the people who don't own cattle, they are unlikely to come to the vaccination point. And sometimes, especially when it's hot, the dogs are unlikely to follow them up to the vaccination point. Now coming to our vaccination figures, the results which came from the vaccination figures, how the pilot phase have influenced the total vaccination dogs in 2016 is that the total dogs vaccinated in the northern communal area were over 62,000, of which 30% of that came from the targeted area, which is Oshana region. And it was now seen feasible to conduct mass dog vaccination campaign from the pilot phase. Hence, a rollout was now done to the rest of the NCA regions, which is Kunene, Omsati, Oshana, Hangwena, Oshikoto, and the Tukavango region and Zambezi region. That was now done in 2017. And a total of dogs and cats vaccinated were over 110,000 in 2017, of which cats, they represent a minimal ratio of that, which is less than 10%. And it was an estimated coverage of 69%. And in 2018, we saw a little decline in total vaccinated dogs and cats, which was over 80,000 dogs vaccinated. Of course, such work has been well documented and described and has been published. The impact of dog vaccination on rabies incidence in Namibia, both in animals and humans, was documented immediately, whereby the rabies surveillance has increased, and this shows that there were more suspected cases which were reported, and the rabies positivity both in dogs and human has also reduced, as shown on the figure on the right hand side. However, there has been an increase on the negativity rate, and such a problem has been addressed by erecting more of the quarantine houses or quarantine facilities in order to allow suspected cases to be quarantined over a period of prescribed time before they can actually be certified free of rabies. And such quarantine facilities are now put up at most of the veterinary facilities from the hotspot areas. It's also worth mentioning that such work has been well described and published, and they can actually be accessed for further reading. Due to the limited resources, we targeted the hotspot area as our surveillance data, which mostly covers the 4 regions, famously referred to the all regions in Namibia, which is the Omsati, Oshana, Ohangwena, and the Oshikoto regions. And the graph above shows the red dots, which represent the rabies. Both the red and the blue dots represent the surveillance data, of which the red one are the positive cases and negative cases are the blue one. And the graph below, the map below, sorry, it indicates the red dots, which are the location of vaccination points around the surveillance data. Until 2018, campaign management has been paper-based, which is very cumbersome and running the risk of missing favorable information. And it also takes time to compile and document and to analyze and document the data. So as a result, by 2019, we started using the GARC data logger which is a gadget to capture the vaccination data, instantly download them, as well as upload them up to the computer, and be able to visualize from the lab bulletin. And the advantage of using such a gadget is actually easy to use, and it requires few people to manage the campaign from the team. The visualization of vaccination locations is via the Rabies epi bulletin, and the map on top, it shows the red dots, which is the campaign information or campaign data for 2019, and the black one is the campaign data for 2020. And the lower map, it shows the vaccination location around the rabies hotspot area, of which the positive cases are represented in red dots. The data loggers also gave an opportunity to visualize our daily and cumulative vaccination data via Rabies epi bulletin, and furthermore, it also gave us an opportunity to visualize data based on the species. It's shown on the graph below on the left, and also by sex as well as by age. And such visualization also presents a good opportunity for better campaign monitoring purposes, and such data are also crucial for future campaign planning. Cross-border collaboration is one of the crucial components of our strategy. As they said, diseases knows no border, and the rabies is of no exemption. There are existing collaboration with other neighboring countries through certifications. However, with Angola, the situation is more unique, and it's because of the uniqueness of the open border we share, which now stretch over 1,000 kilometers. Hence, rabies is a cross-border problem. We jointly developed an implementation plan across the border, covering the southern provinces of Angola, provinces of Namibia, Huila, Kunene, and the Kwando Kubango, and which are now bordering the Namibian northern region. And Angola, as such, have now started their campaign program in July 2020. It's also worth mentioning that our implementation plan is subjected to annual review of implemented activities and planning of future activities. This is done jointly with most, if not all, our stakeholders, including the international collaborators, the OIE, the FLI, as well as the federal government of Germany. It's always represented. And the aim is to measure the progress and acknowledge our challenges, as well as seek the best solutions as we move forward on how to address such challenges. The important elements of a rabies elimination program are very, very crucial to note, as they play a very big role during the implementation of the program. You should have a legal framework under which your national control plan is operating, and it has to be politically supported for commitment purposes, and there has to be a leadership who are committed, and they are the driving force of the implementation of the program. And public as well as stakeholder sensitization is very, very crucial for future commitment as well as future engagement, since rabies is a public good, and this has to be implemented under one health approach, or there has to be an aspect of one health approach. Hence, there has to be an intersectoral collaboration. Capacity building is very, very crucial, especially among the staff or among the people who are on the forefront of implementing the program. And capacity is human resources as well as material resources is very, very crucial for the program. A good advocacy plan which now seeks for support to fund the program is also very, very important. And there has to be a surveillance system in place which has to inform your planning of your elimination program. And such surveillance as well as the implementation program has to be subjected to monitoring and evaluation. Having talked about challenges, of course, Namibia is of no exclusive. We are a vast country with people who are sparsely living, especially in the populated northern communal area, where dog rabies is an endemic issue. And we share parallel border with neighboring countries. And one of the issues that becomes a challenge is the nomadic lifestyle of people moving in search of grazing with their livestock, at the same time also with their dogs, and that alone also influences the it's influenced by the climatic change. It now results in affecting the campaign timing. The issue of the targeted populations as well as the higher dog population turnover is also one of the challenges that we experience, and the unforeseen budgetary constraints at the government level, which also now coupled with animal and human disease outbreaks, which might take up a priority over rabies. A very typical example is the current situation around COVID-19. Another issue is the surveillance, which we mostly depends on community to report, as well as also samples which are being presented at local hospitals. Hence, collaboration at the sectoral level is very, very crucial. As we move forward, we foresee that targeting vaccination campaign, focusing on high-risk areas and providing the vaccination coverage at a local level, it becomes our priority. And of course, coordinating with neighboring countries in implementing our vaccination campaign. And as a country, of course, we have set ourselves a level of commitment towards rabies elimination by submitting our elimination commitment letter to the United Against Rabies in February 2019. And at the moment, we are working, or we are preparing to submit an application for endorsement by the OIE for our official national control program. Having said that, I thank you, and let's commemorate and observe the World Rabies Day by spreading the message of today, which is End Rabies, through collaboration and the vaccination, so that we end rabies here. I thank you for the opportunity and for listening to me.
Thank you, Dr. Atingo, for this comprehensive and very informative presentation. I've seen that your activities generated tangible results. You have mentioned several critical elements that should be considered to fight rabies at the national level, from multi-stakeholders collaboration to public awareness. And I think that some further details will be discussed later, because I've seen that some questions are raised by the participants. So I think later we will have a chance to address a couple of questions. Thank you again, and I pass the floor to Tenzin.
Okay, now we will go for presentation from Nigeria. Dr. Okuli is a public health veterinarian with over 30 years of experience in both private and public sector. She currently works as a consultant veterinary public health specialist in the Zoonosis Control Unit of the Public Health Division, Department of Veterinary and Pest Control Services, Abuja, Nigeria. She is also the desk officer for rabies and One Health focal person in the department and coordinates rabies control program in the country. She will share the mass dog vaccination experience in Nigeria. Over to you,
Everyone,
Dr. Okuli.
it's my pleasure to be sharing the Nigerian experience of mass dog vaccination with you this morning. I especially want to thank the Director of Veterinary and Pest Control Services and the CVON of Nigeria, Dr. Ladiron Alabi, for giving me this opportunity. This presentation will focus on introduction, review of rabies outbreaks in the last 5 years, review of mass dog vaccination in the same period, discussions and conclusions. This information, we all know, rabies is 100% vaccine preventable and affects all warm-blooded animals, including man, with a near 100% fatality rate if post-exposure prophylaxis is not instituted early. Rabies is on the increase across continents, and dogs account for 99% of human deaths resulting from this disease. Hence, the Tripartite partners are united in the fight to end dog-mediated rabies by the year 2030. Rabies was first reported in Nigeria in 1912. 4 serotypes have been identified. Majority of dogs are unlicensed and roam freely. It's important to note, however, that most of the dogs referred to as stray actually have owners. The dog population is estimated at 20 million. Nigeria is located in the West African coast with a population of approximately 200 million people in an area of over 300,000 square kilometers. It is made up of 36 states and the Federal Capital Territory and run by 3 tiers of government. Federal government, through the Department of Veterinary and Pest Control Services, headed by the Chief Veterinary Officer, is responsible for development and coordination of national animal health policies. States are responsible for the control and prevention of animal diseases, while the local governments are the lowest administrative level. The structure of the Department of Veterinary Services. The Director and Chief Veterinary Officer superintends over 5 technical divisions. Veterinary Public Health Division is one of them, with zoonosis as a unit. These institutions are related to the veterinary services, being linked in animal disease surveillance and reporting, as shown in this diagrammatic representation of animal disease reporting channels in Nigeria. Review of rabies outbreaks in the last 5 years, 2015 to 2019. This table shows the suspected and confirmed cases of rabies from individual states summarized in the next table. Out of 1,918 suspected cases in this period, only 118 were confirmed by sending specimens to the National Veterinary Research Institute from Plateau State. This information is from 20 states only. The summary of annual outbreaks and confirmed cases reported from 2015 to 2019 through the National Animal Disease Information and Surveillance System. Out of 15 states that reported in this period, 216 outbreaks were recorded, with 245 confirmed cases, 3 of which were in non-canine species. The spatial distribution of the outbreaks over the same period. The National Reference Laboratory is located in the state with the highest number of cases being reported. The state here is Plateau State. The NVRI is right here, and you can see that there are over 140 cases being reported over this period here. The outbreak distribution by month shows that rabies outbreaks occur throughout the year, with peaks around the months of July to November. This coincides with the long vacation when young students spend more time outside playing with their pets. The review of mass dog vaccination campaigns in the last 5 years. Mass vaccination and routine vaccination records from states summarized in the A total of 318,294 dogs were vaccinated during this period. 142,386 dogs during mass vaccination in 15 states, and 175,908 during routine vaccination. Vaccination teams set up by state. Teams were either made up of government staff alone or with the Nigerian Veterinary Medical Association, and sometimes with One Health partners and or community leaders, as shown by the number of states in each category from 2015 to 2019. The NVRI produced 209,305 vaccines from 2015 to 2019. 185,778 were procured by government and private establishments. Discussions. Most of the discussion points have already been explained by the tables. However, I will highlight some points for emphasis. Rabies is endemic in all 36 states and the FCT, occurring throughout the year, with most outbreaks between July to November. Non-canine cases involving cats and cattle were reported. Increased surveillance and reporting were observed from 2017 due to increased capacity building for surveillance agents in all states, coupled with advocacy and increased awareness creation. Mass dog vaccination is crucial to a successful rabies control program. The first and last successful national campaign held 38 years ago in 1982. Between December 2006 to April 2007, another national campaign was initiated but uncompleted due to paucity of funds. States conduct routine vaccination in government and private veterinary clinics, but organize mass dog vaccination campaign around World Rabies Day and following outbreaks. The banner here shows a successful campaign in Kaduna State in 2017 in one of the local government areas. Vaccination campaigns were preceded by massive enlightenment campaigns involving electronic and print media and local town criers in rural communities. Planning and logistics campaigns were planned around World Rabies Day with the National Veterinary Medical Association and support from the federal government. The team setup has already been discussed earlier. Cold chain, most vet clinics have refrigerators. Coleman boxes, however, with ice packs were used to maintain cold chain for field activities. Mobility, as rural communities were often targeted for mass dog vaccination activities. The teams assembled at vaccination venues individually, while dog owners walked with their dogs to the venue. Vaccination timings were in the morning up to 2 p.m. Duration varied from 1 week to 3 months. The cost of vaccination also varies from state to state, averaging $3 to $4 if using the local vaccine. In the absence of a national program, the state directors of veterinary services coordinate the state campaigns with state NVMA chapters in collaboration with the federal government. Impact of mass dog vaccination on rabies incidence in humans is difficult to evaluate in the absence of comprehensive national data. The same can be said presently regarding the impact on rabies incidence in animals because there was no baseline data to be able to measure impact. The SWOT analysis at a glance strength includes existing veterinary networks across the country, adequate manpower, available capacity for diagnosis. Weaknesses include poor legislation, poor linkages between research and public government, underreporting, poor intersectoral collaborations. Opportunities will include global partners' interest and support, and the threats are from wildlife infection spillover and cultural habits. The challenges identified were lack of awareness, high cost of vaccine, high stray dog population, cultural practice of consumption of dog meat, weak linkages, underreporting, poor legislative framework, parallel disease investigation and reporting systems by One Health stakeholders, porous international land borders, inadequate funding for animal health activities, and poor laboratory networks. The way forward remains to increase awareness creation, advocate for more government support for substantial free vaccination, improve linkages for improved surveillance and reporting, facilitation of the enactment of a dog control law, strengthening One Health platforms at different levels of government, regional collaborations across international borders. We need more partner support to implement national strategic plan for rabies control. Sample transportation and laboratory networks need to be improved and strengthened. From 2015 to 2019, there was massive awareness creation leading to increased surveillance and reporting. Routine and mass dog vaccination were carried out, and dog population and ecology studies also were carried out. Now in 2020 and over the next 5 years, we plan to have enhanced publicity and media engagement to encourage responsible dog ownership and adoption of routine annual vaccinations, as well as targeted mass dog vaccinations to cover at least 70% of estimated dog population. From 2016, as we approach the deadline of 2030 for elimination of dog-mediated human rabies, sustained vaccination, monitoring, and evaluation will be carried out. Mass dog vaccination, in conclusion, is key to any rabies control program. Nigeria has the technical and organizational capacity to eliminate rabies by the year 2030 with the political will and adequate regulatory provisions and funding. Thank you for listening.
Thank you, Dr. Okoli. Thank you, Dr. Okoli, for the nice presentation, giving an overview of the challenges and success in Nigeria. Now, I would like to request the presenters to kindly respond to the questions on the chat box. I can see there are a lot of questions being raised by the audience and on the chat box, and I would like to request the presenters to respond to the chat, make a response to the audience in the chat box. Thank you.
Thank you, Tenzin. We can move to the next presenter, and I'm pleased to introduce Dr. Helama Sayed Mergani Abdallah. Dr. Abdallah is a veterinary officer at the Ministry of Animal Resources and Fisheries Undersecretary Office in Sudan. She currently serves as a Sudan rabies focal point since May this year. Previously, she worked at the Arab Organization for Agricultural Development as expert assistant and also serves as a member of several committees in the ministry. She will share the mass dog vaccination campaign experiences in Sudan. Dr. Abdallah, floor is yours. Thank you.
Hi, everybody. Today I would like to share with you Sudan experience, the mass dog vaccination campaign. First, I would like to congratulate all of you, or also ourselves, by the coming of the World Rabies Day. Sudan, the rabies is endemic in Sudan since 1904, and it's a continual threat of public health as transmission to human. The dog-mediated also is a large-scale losses of livestock care each year, causing as you know, economic and social developments. Many states shows sporadic cases in the last 5 years. Some states are at risk of rabies, like North Darfur, West Darfur, North Kordofan, Khartoum State, River Nile, and Jazeera. We have a national strategy here in Sudan. It's available. This strategy aims to implement a mass dog vaccination campaign, also control of stray dog population, enhance the surveillance of rabies in humans and animals, and it's also aimed to public health education and awareness on rabies. At the World Health Organization recommended that the vaccination of at least 70% of the population in the country or the country over the world, but we're facing challenges here in Sudan to achieve this percentage because we're facing many obstacles. So we use the vaccination as static points. It's a free vaccination campaign. Also, we have sporadic paid vaccination in private veterinary clinics on request. There is many steps that we apply for implementation mass dog vaccination campaign. I will give you a brief about the past vaccination campaign in Sudan. It started in 1953. Since that time, there is an annually vaccination program. This vaccination program is aimed to control rabies in the states that is at risk for rabies. We follow many steps for these vaccination programs. There is preparation of the vaccine supplies and equipment, and then a public awareness campaign to increase people knowledge through media, leaflets, posters, and announce for vaccination in all localities. And then conduct the vaccination campaign by provide the free vaccination in assigned vet hospitals and clinics in all localities. The campaign durations about 3 to 10 days, according to the locality, according to the size of or the number of dogs in these localities. Finally, there is a monitoring and evaluation of these campaign activities. The picture shows the mass dog vaccination, the last dog vaccination campaign in Khartoum, January 2020. Why we say that Sudan experience is successful? We facing many obstacles to control rabies, but limited fund to vaccinate enough dogs, comparing with the recommended percentage. Also, there is a high cost of rabies vaccine. The private companies imported it outside Sudan. And then also we have difficulties to control stray dog population. But although these obstacles, Sudan also reported the less number of the rabies cases, as it's shown here in this slide. In 2018, we have 5 dogs cases. Also in 2019, we have 5 dogs cases. There is, here in Sudan, we say there is strength to fight rabies. We have a good intersectoral collaboration between the Ministry of Health, also with the Ministry of Animal Resources. Also, we have a personnel and availability of laboratory diagnosis, especially in the central veterinary laboratories in Khartoum. But we are facing problems for diagnosis in the state. But the central veterinary laboratories have a capacity or a personal ability, to diagnose rabies. In the past, the PaRaCoN vaccine was produced in this laboratory, but now it's stopped. To achieve our goal to control rabies, we need availability of funds to implement rabies programs. Also, we need to support laboratory rehabilitation and maintenance of the equipment for diagnose rabies in federal and states, as I mentioned. Also, we need to improve vaccine production and training of the personnel. Finally, I would like to thank the Tripartite, the WHO, OIE, and FAO for their for their effort to eliminate the rabies by 2030. Also, let's say together, end rabies, collaboration, vaccination is the theme of World Rabies Day this year. Thank you.
Thank you, Dr. Abdallah, for this interesting presentation. And we close this first session with country's presentation, and we now are going to discuss a bit with the presenters. As my colleague Tenzin said, that presenters are also invited to respond to the question raised by the participants. Actually, very interesting presentation that stimulated many questions I've seen in the chat box. This would be very good if the presenters can address the response through the chat box. This will optimize our time for discussion. But I would like just to pose a question to Namibia, Dr. Atingo, because Namibia has implemented a wide-scale mass dog vaccination campaign since 2016. And your presentation indicated the reduction of both dog and human rabies in the project area. For rabies, if the vaccination campaign is not implemented regularly, this could come back quickly to the endemic situation. So what do you think about the sustainability of the program, even though when rabies will be eradicated? Do you have any plan about that? Thank you.
Rauna? Is Rauna online?
Yes,
Rauna may
Rauna
respond.
is.
Yes, yes.
Thank you very much, Alejandro, for the questions about sustainability. If I got it correct, right?
Correct.
Yeah. Let me start off to say the Namibia strategy control program came a long way, and it has actually been driven by the actual fact which is happening on the ground as far as rabies control is concerned. And having taken it at the moment as a project because of the involvement of other stakeholders and partners in the control, it has been actually a program for the country since rabies is a notifiable disease in the country. Looking at the sustainability will be there, looking at the fact that much of the funding is actually coming from government and it's actually going along with other priority diseases like foot and mouth disease and lung sickness for cattle. And if the rabies control will be affected, that means equally other diseases will also be affected along their way. However, what I can tell for now is that the priority for rabies in the country is equally important as other diseases as well. If maybe I have answered your question.
Thank you, Rona. Yes, thank you very much. Tenzin, over to you.
Thank you. So I saw that the presenters has responded to the audience question on the chat box. So to Dr. Muturi Kenya, I would like to ask one question. The main purpose of mass dog vaccination is to have adequate coverage among the dog population, which should then reduce rabies incidence both in dogs and in humans. And you have responded in the chat box that during your annual mass dog vaccination campaign, you have covered around 59 to 67%. But what is missing is what has been the impact of vaccination campaign, particularly in terms of rabies cases in dogs and in human. Has the rabies cases in dogs and in human reduced, over the years after the mass dog vaccination campaign?
So I hope
Yes.
the answer to that is for us, we don't have, I think, adequate data to make a very strong claim for that case. In the pilot areas where we have done this work, I'll give the example when we are seeing a reduction in the number of worldwide cases. However, in terms of rabies as a disease, because of the challenges in diagnosis, it's becoming a challenge to make a link on whether there's an actual reduction. However, to sort of mitigate against that, currently in one of the areas, there's an active surveillance system for health for human rabies. We are using the ABCM approach, the Animal Fight Management Centers. And so we hope by the end of 2 or 3 years with continued vaccination, we'll be able to have valid data from enhanced surveillance. And we'll be able to
thank you. Thank you, Dr. Matthew, for your nice response. Now, may I ask Nigeria, Dr. Okuli, you have listed several challenges to organize a mass dog vaccination campaign in your country, and it appears from your presentation that the dog vaccination program is only conducted routinely at the veterinary centers and not as a countrywide mass dog vaccination campaign due to several challenges. What do you think is the best approach to pool resources and also engage multi-stakeholders to participate in the rabies elimination program? Is there Dr. Okuli?
Yes, good afternoon.
Yes.
Yeah,
Good afternoon.
Yeah, thank you for the question. In Nigeria, like I stated in the presentation, we've had mass dog vaccination nationwide in the past, but presently the states, which are independent to some extent, are conducting mass dog vaccination in targeted areas where they have the most challenge of rabies. But we have plans, if the funding is approved, to have a national, which will cover all the states at the same time. But right now, mass dog vaccinations are being conducted at the state level.
Okay, thank you. Thank you for your response. Alessandro?
Yes, yes, thanks. And I have a question for Dr. Abdallah from Sudan, because we know that how important is the multi-stakeholder approach under One Health to fight rabies. It was mentioned several times during this presentation. So I wonder if you could say a bit more about the involvement of the several partners in your country to fight this disease. Thank you. You are on mute. Sorry. Please unmute the microphone. Perfect.
Good afternoon. Sorry. I'm so glad to be here with you this day. Yes. In Sudan here there is many partners they are work together to eliminate rabies. Okay, the Ministry of Animal Resources, also Ministry of Health, also Ministry of Interior Affairs. As I mentioned in my presentation, we have a good collaboration between Ministry of Animal Resources and Health. There is a technical, sharing technical committee between two ministers. Also, they coordinate all activities regarding the rabies elimination here in Sudan. Also, there is a memorandum of understanding signing between the two ministries to collaborate together for all issues that concerning rabies elimination here in Sudan. As I mentioned, this is one of the strengths that we have to eliminate rabies. Thank you.
It is involved also other field partners that are working on the disease.
Partners, you mean?
Like NGOs or
yes,
private vets.
Yes, we have it. We have it, yeah.
Thank you.
Thank you.
Thank you.
Okay.
Yes,
thank you all the presenters for sharing your experience, country experience on rabies mass dog vaccination campaign. Now we will go to the next session. We will have sharing of experience using oral rabies vaccine in dogs by Dr. Ed Boss. Dr. Ed Boss is an oral rabies vaccination expert from Germany. He has been working on oral rabies vaccination to free-roaming dogs for over 30 years, starting as a PhD student in Germany. Subsequently, he worked at IDT Biologica in Germany for 25 years. He currently works at Ciba Santé Animali, Department of Veterinary Public Health, France. Over to you, Dr. Boss.
Dear ladies and gentlemen, I would like to use this opportunity to introduce to you the concept of oral vaccination of free-roaming dogs against rabies. I guess by now every one of you have heard about this global plan to eliminate dog-mediated human rabies by 2030. We think it's feasible simply because all the tools needed are available, whereby the most cost-effective method to eliminate the disease at its source is by vaccinating dogs. These mass dog vaccination campaigns have proven to be extremely successful and cost-effective in many countries around the world. And of course, most important is achieving a high vaccination coverage. Unfortunately, in many countries, you have a lot of free-roaming dogs. And how can we reach these dogs? How do we get our vaccine into these dogs? Don't forget, these free-roaming dogs play a very important role in the transmission of rabies. Of course, we can try to catch the animals and then inject them. But this is a very cost and time-intensive method. Furthermore, there are certain animal welfare issues associated with it. And most importantly, it becomes less effective with time, simply because the dogs are more difficult to catch. So the big question, is there any other method available that we could use to vaccinate these free-roaming dogs? Yes, we do have oral vaccination against rabies. Hereby, a sachet filled with a vaccine is incorporated in a very attractive bait and offered to the dog. When the dog is offered the bait, it will start eating it, and with his teeth, it will perforate the sachet, so the vaccine is released in the oral cavity where it's absorbed via the tonsils and the mucous membrane, and it is presented to the immune system. It sounds almost too simple to be true, but it actually works. It was originally developed for foxes. In Europe, we do not have dog-mediated rabies anymore, but this little wild carnivore, the red fox, is the major reservoir species of the rabies virus in Europe. And as you can see, fox-mediated rabies was widespread in Central Europe during the 80s. We had more than 10,000 cases reported every year. So when countries started implementing oral vaccination, you can see we had a drastic decrease in the number of rabies cases. Actually, in 2070, in Central Europe, fox-mediated rabies did not occur anymore. So people started thinking after the initial successes, well, if it works for that fox, why wouldn't it work for that free-roaming dog? And of course it does. The concept of oral vaccination is based on three components or pillars: the vaccine, the bait, and the distribution system. All three are equally important. The vaccine should not only be highly efficacious after a single dose, it should also be safe, not only for dogs, but also for other animals that live in that same environment, but also for humans, of course. And the bait should be highly attractive and ensure timely release of the vaccine in the oral cavity. And finally, the bait distribution system should optimize bait availability to your free-roaming dogs, meanwhile preventing especially human contacts with the vaccine virus. Why is that avoiding human contact with the vaccine virus so important? Well, simply, all oral rabies vaccines are based on live replication competent viruses that can also infect humans. And dogs and humans share the same environment, and there is a lot of contacts between these two. And therefore, stringent safety requirements are set up not only for the vaccine, but also for the bait distribution system by, among others, WHO. But also OIE has set up a set of minimum safety requirements for these oral rabies vaccines as specified in this dedicated chapter on rabies in the terrestrial manual. Now actually, when it comes to the bait distribution system, there's only one system that's endorsed, and that's called the handout and retrieve model. How does it work? Simply, you only use oral vaccination for dogs that you cannot vaccinate by the parental route. And it works like this: when you encounter such a dog, you only offer the bait directly to the animal. In other words, if it does not accept the bait, you recollect the bait. In case he accepts it and starts chewing on it, you wait, and when it discards the perforated blister, you also recollect that blister. This way you limit risk of human contact with the vaccine virus, and you have limited wastage of vaccine baits. And this way you can easily integrate it into traditional parental vaccination campaigns like Central Point or door-to-door. Now, I want to share with you some of the results obtained during field studies all around the world. We first go to Turkey, to Istanbul, where we added the oral vaccination component to the traditional mass dog vaccination campaigns. And as you can see in these urban settings, we were able to increase the overall vaccination coverage by oral vaccination with 20%. So the overall vaccination coverage was well above the famous 70% required. In the Philippines, we had a complete different situation. Here, all the dogs are owned, all the dogs are free roaming, but almost none of the dogs can be handled by their owner. So again, doing a door-to-door campaign and adding oral vaccination, we were able to increase vaccination coverage to 67%. So the added value of oral vaccination depends, among others, on your structure of your population, of your dog population. So in areas where you have a lot of free roaming and or ownerless dogs, oral vaccination can make a big difference, because in a lot of countries these dogs are simply not accessible for parental vaccination. In another study we conducted together with CDC, Atlanta, United States, that was in Haiti, we also had a door-to-door campaign and added the oral rabies vaccination component. And of course, we used the handout and retrieve model. 97% of the dogs over the bait accepted it. 93% of the dogs over the bait actually punctured the sachet. And 95% of the sachets were recovered by the vaccinators or swallowed by the dogs. You always have a couple of dogs that take the bait, ran off in the bushes, and you don't know what happens with it. Almost 80% of the dogs had evidence of rabies antibodies already 2 weeks after bait acceptance, and no adverse events in dogs and humans were reported after the campaign. We also compared this door-to-door plus ORV campaign with two other vaccination strategies. We had a only central point vaccination campaign, and we had a central point vaccination campaign with a capture, vaccinate, release method to vaccinate all the inaccessible dogs in that area. But as you can see here, The highest vaccination coverage was achieved with the door-to-door plus ORV. Interestingly, it was not only most effective in terms of vaccination coverage, it was also more cost effective. Despite the relatively high cost of an oral rabies vaccine bait, compared to a parental dose, it was the most cost-effective strategy, largely due to the increased efficiency to target these less accessible dogs. In another study we did with Mission Rabies in India, this was actually confirmed. Here we compared the door-to-door campaign with capture, vaccinate, and release for the inaccessible dogs, or door-to-door plus oral rabies vaccination, also targeted at the inaccessible dogs. And also here, the ORV component was much more cost effective than the capture, vaccinate, release, simply because instead of working with teams consisting out of 7 people, we worked with teams, with the ORV teams, with only 2 people. Hence, you save a lot of money when it comes to salary, etc., etc. And these savings easily compensate for the higher cost of the vaccine bait. And of course, just as important, ORV was much more efficient in targeting these inaccessible dogs. So to summarize, oral vaccination offers a possibility to reach dogs inaccessible for parental vaccination. It increases efficiency of campaigns by reducing time and therefore money required to capture and restrain these dogs. It reduces capture stress not only for the dogs but also for the vaccinators. And as a complementary tool to parental vaccination, it can increase herd immunity to levels required to interrupt the transmission cycle. And with that, I want to thank you for your attention, and I want to thank OIE for giving me the opportunity to share this with you.
Thank you, Dr. Ed Bose, for your very interesting and comprehensive presentation on the use of oral rabies vaccine in dogs. And I believe that oral rabies vaccine may act as a complementary to increase our vaccination program, especially in countries where there are a large number of free roaming and stray dogs. There are a couple of questions from the audience, and I would like to ask you to respond. Like the questions are, what is the cost of the oral vaccine? And what about the availability and cost of this approach? And another question was, what is the total cost per dog vaccinated with an oral vaccine compared to parental vaccination? And other question is the vaccine thermostable in case of oral vaccination? Or how long does the vaccine stay viable in the open air condition? And other question was, is there another alternative apart from using beds? And has there been any reported vaccine-induced rabies cases with ORV? Can you please respond?
Yes. The first question was about the cost. It's very difficult to give a fixed cost for the bait because that depends, among others, the import taxes induced by the country. But like I showed in the example of Haiti and the example of Goa State in India, actually when you calculate overall cost, so the cost per dog vaccinated, including salary, everything, the higher costs that you have to pay for a vaccine bait will be compensated by the savings you make in salaries and all these things. So yes, if you implement it correctly, oral vaccination can be cost effective. The other question was about thermostability. That always comes up. The baits need to be transported frozen, kept frozen till you use them in the field. In the field, you take with you in your cool box, and then basically do this while we use the handouts and retrieve model. We only shortly take them out of the cool box, give it to the dogs, and then the dog will eat it. So basically, it is just the storage and the transport to your vaccination area that you have to assure your cold chain. Once you go in the field, it's only that very short moment from your cool box to giving the bait to the dog. Then there was another question, I think, about the vaccine-induced
version of Yes.
The vaccine-induced cases, you have to imagine we have many different oral rabies vaccines are available. Mostly they're used for wildlife. So you have very old ones, first generations, and you have very new ones, the third generations. And there's a big difference in safety level. So with the first generation vaccines that were used and are still used in Europe, and also in North America previously, yes, we did have vaccine-associated rabies cases in wildlife and livestock that found one of these first-generation vaccine baits. So this, again, you cannot answer generally. This is depending on the vaccine candidate you select. And thanks to OIE, we have a dedicated chapter on the minimum safety requirements. So everybody can say, well, does your vaccine candidate fulfill all these requirements? Then it's safe to use. The last one was a question on reversion of the vaccine inside the animal. And that is basically the same answer. It depends on what type of vaccine you use. You use the very first oral vaccines, the first generation. Yes, there was not reversion to virulence. It's more residual pathogenicity of these first generations. Newer vaccines are much higher attenuated. And so far we have had no reports of such cases. Thank you.
Okay, thank you very much. So there are a couple of questions on the chat box. You may please respond to the audience. Thank you.
Yes, I will.
Okay, thank you. Over to you, Alexander.
Thank you, Tenzin. I'm going to present the next presenter. I have the pleasure to introduce Dr. Tennyson Williams. Dr. Williams is the Director for World Animal Protection responsible for Africa, based in Nairobi. He is an international development specialist and has over 20 years experience in the development sector with UNHCR, International Livestock Research Institute in Nairobi, and Action Head International. Tennyson has held a number of senior management positions directing African-wide regional programs with multi-donor funding. Dr. is also involved in a number of research and consultancy projects in Africa. He will present on World Animal Protection role and activities towards rabies elimination program in Africa. Thank you. Over to you, Dr. Williams.
Good morning, good afternoon, good evening, wherever you are. Welcome to this presentation. My name is Tennyson Williams, Director for Africa, World Animal Protection. World Animal Protection is a global animal welfare organization that has been focused on promoting good animal welfare practice for the last 50 years. Our vision is a world where all animals are free from suffering and cruelty, and our mission is to move the world to protect animals. For today's presentation, my topic is All Eyes on Dogs, End Rabies, Collaborate and Vaccinate, consistent with the theme for this year's World Rabies Day celebration. As an organization, we are dedicated to enhancing welfare and ending cruelty to animals across the world. And like I said earlier on, this we have been doing for the last several years. We and our partners share a common view that a sustainable world is one where animals are free from suffering. Dog solutions to 0 by 30. We are saying the world has been focused in treating rabies in humans for far too long, and that we have been working to end inhumane culling of dogs due to rabies. But our position right now, ladies and gentlemen, from the experience we have, is that mass killing of dogs and vaccination of humans will never stop rabies, in our view. A smart mix, therefore, of humane dog population management, inclusive of mass dog vaccination, responsible dog ownership, targeted sterilization, educational campaigns in communities, and emphasis on governments owning rabies control programs is the way to go. It only costs $4 to vaccinate a dog, but it will cost £180 to treat a human who is infected with the virus. Therefore, we must shift our focus to dogs because they hold the solution to elimination of the disease. We have come up with a blueprint, which we call the Dog Population Management Blueprint, and it has 8 components, ranging from education to legislation to euthanasia. Depending on your situation, you can choose whichever of these components that will apply in your situation. With the advent of the COVID-19 pandemic, we have seen pets also affected both from their health and well-being, and cases of dogs and cats testing positive and even dying. And this has brought on new questions on the human-pet role in the greater public health agenda. Of course, due to lack of information globally, thousands of pets have been either killed or abandoned. And we are saying this will only go to amplify other public health issues that are being addressed in the area of pets. From our experience working in Makueni County in Kenya through a pilot initiative, which we started in 2014 and ended in 2018, we recognize that there is need to sensitize residents for them to be actively involved in such initiatives. And for you to scale up such initiatives, we need to take advantage of the opportunities, but also learn from the challenges. Our efforts in Makueni involved mass dog vaccination. We also focused heavily on education, including training of teachers and teaching of children on rabies, responsible dog ownership, etc. And all of this we did in partnership with the Zoonotic Disease Unit in Kenya, the OIE, Washington State University, the Kenya Medical Research Institute, and CDC, among others. Some of the outcomes and lessons from the Makueni initiative is that government and communities must buy in for success to be achieved. And of course, we were able to reach over 70% coverage in our experience working in Makueni, which is critical for us to obtain herd immunity. And dog sensors and knowledge and attitude practice survey on community attitudes towards dogs is very essential for rabies control. We had a list of recommendations ranging from ensuring you take a multi-sectoral approach towards rabies control and elimination, but also including teachers and pupils as change agents in the control of rabies and responsible dog ownership. Those are very critical, and you need to enact bylaws to make annual rabies vaccination and certification mandatory. This will serve as an impetus for those community people who are involved in the project. So a number of these recommendations are very important from our experience. In Sierra Leone, ownership was with the Ministry of Agriculture, Forestry and Food Security. And in September 2017, we launched the National Rabies Elimination Strategy and Dog Population Management for Sierra Leone. And we worked with the Freetown City Council for capacity building. And by end of this year, we should be evaluating the achievements from that project. In Zanzibar, all the way from 2000, we first engaged the Zanzibari government with the main goal of improving animal welfare policy and practice. And by 2013 to 2016, we had a full-blown integrated rabies prevention and elimination program, which was led by the government of Zanzibar. And by 2017, in partnership with the Global Alliance for Rabies Control, the program was handed over to the Zanzibari government. To date, our partnership with the Global Alliance for Rabies Control continued with work over 16 countries in sub-Saharan Africa through the Pan-African Rabies Control Network initiative. In Ghana, in 2016, we sponsored and participated in Rabies in West Africa conference. And by 2017 to date, we have been working with Rabies in Control in West Africa initiative in Ghana, and we have supported the Directorate of Veterinary Services to run World Rabies Day events through dog population management initiatives and mass dog vaccination programs. In conclusion, it is very important for us to continue to emphasize that rabies elimination should be a key priority at national level in particular, and with all agencies that are interested in good animal welfare practice. We have submitted We have also outlined our approach in our published resource entitled Humane Dog Management, Better Lives for Dogs and Communities. And we have also published our All Eyes on Dogs report, which is a recent piece of work that we have done. And last but not least, we continue to reiterate our willingness to cooperate with others, including government across the continent, so that we can share our experience and knowledge that will enable dogs and humans to live in harmony. As an organization, it is important we continue to register our unflinching support for this initiative, because animals, especially dogs, continue to be a critical component of our society until and unless we take a comprehensive approach, particularly from a dog population management perspective. Rabies control will be a difficult thing. And we are calling on all partners, again, including governments, to make this a priority disease. Thank you very much.
Thank you, Dr. Williams, for this interesting presentation and for sharing the role and the activities that the World Animal Protection is doing towards the rabies elimination program. So I invite the participants to pose questions in the chat. But in the meantime, I have comments or questions for Dr. Williams. So you have made a clear and loud statement that culling of dogs will not control rabies. As an international animal welfare organization over the last many years, I would like to know if the culling practice is stopped or reduced by applying your good animal welfare practice and your engagement that you had with governments and local communities in the continent. And also, how do you see the animal welfare status while organizing mass vaccination campaign? Thank you.
Okay. Is Dr. Williams?
Hello?
Yes.
Can you hear me?
Yes, yes.
Thank you.
That was a great question. Thank you very much. So we continue to reiterate the position that we take on this matter, because this is really born out of true experience over the last several years that we have been involved in this business. Dog culling can only make matters worse because there are massive welfare difficulties, the dog being the victim and being blamed for situations of all, that alternative is based on the fact that what we have experienced does not offer the solution. It is only $4 to vaccinate one dog compared to try to address this disease when the virus is in humans. And the experience, like many others know, is very costly. Families cannot afford, and hence rabies is a disease of poverty. We got to make sure that poor people do not continue to bear the brunt of this disease, and at the same time, we don't continue blaming dogs for really being the responsible partner in this whole business. So responsible dog ownership is critical. Humane dog population management is critical. Dog population control is critical, and mass dog vaccination is at the heart of all of this. And that's why we said a smart combination of all of this is the only way out. We have to be able to demonstrate to political leaders, decision makers, those who have influence in resource allocation, to understand how impactful this virus can be on constituencies they represent. But not only that, that there is a solution which is affordable as opposed to the cost of allowing this disease to continue to ravage. You may know that it costs at the moment about $8.6 billion annually in terms of the cost of this disease. But what we are saying, and research is pointing to that, over 10 years, it will only cost an average of about $6 billion. So it makes good sense to actually use the approach we are proposing collectively to address this situation, as opposed to continuing to kill dogs. And dogs had been killed for the business of eliminating rabies even before some of us were born. And the solution, and it has not been found to be a good solution. And as an animal welfare organization, we say it is completely wrong to continue to blame dogs, even when we know and there is evidence that dogs hold the solution. Let us invest in vaccinating the dogs, and let us not make the mistake of continuing to advance PEP as a solution. It will not work. Thank you very much.
Thank you, Dr. Williams, for your comprehensive response. And I would like to invite you to check on the chat box if there are other questions raised addressed to you. So I would be really grateful if you can address them. And Tenzin, I give the floor to you for the follow-up.
Okay, thank you. In human and in animals, and OI tuning rabies diagnostic capacity building. First, we will have presentation from Dr. Rita. Dr. Rita Mani is Dr. Rita Mani currently works as an additional professor, Department of Neurovirology, WHO Collaborating Center for Reference Research in Rabies at the National Institute of Mental Health and Neuroscience. Our major focus of work has been in the field of rabies, including clinical, diagnostic, and preventive aspects. So she will talk about rabies diagnostic techniques, case management, and surveillance in human. Over to you, Dr. Rita.
At the outset, I thank the organizers for inviting me to speak in this webinar. In the next 10 minutes or so, I will briefly talk on the diagnostic techniques, surveillance, and case management in human rabies. As most of us are already aware, following an exposure, which is most often a dog bite, the average incubation period in rabies is about 20 to 90 days. So in a few cases, it may be as short as a week or more than a year. Two clinical forms of rabies are well recognized: the classical furious or the encephalitic form and the paralytic form. Irrespective of the clinical presentation, in the absence of any intensive care, death is certain in about a week or so following onset of symptoms. In clinically suspected cases, a laboratory confirmation helps to distinguish from other conditions which may mimic rabies. Early laboratory confirmation helps avoid unnecessary tests and treatments and aids in patient management. It also helps in case closure and grief counseling of caregivers. Infection control protocols and public health measures can be initiated, including prophylactic vaccination to close contacts of the patient as needed. Laboratory testing can help characterize the virus and plays a vital role in surveillance and estimation of disease burden, and especially to monitor areas which are rabies-free or are on the verge of being declared rabies-free. WHO recommends that one or more of these tests should be positive for confirmation of a clinical case. That is, presence of viral antigens or isolation of virus from clinical samples, presence of specific antibodies in the CSF or serum of an unvaccinated person, or presence of viral RNA in clinical samples. Laboratory confirmation can be done using samples collected ante-mortem or post-mortem. Several diagnostic testing methods are available. In our laboratory, which deals with a large number of clinical samples from suspected human rabies cases, we use this algorithm for diagnostic testing. For antemortem samples, we perform a RT-PCR for detection of viral RNA in saliva, nuchal skin biopsy and CSF samples. And we also test for specific viral antibodies in the CSF and serum samples. Now, if any of the samples tested by RT-PCR is positive for rabies viral RNA, a diagnosis of rabies can be confirmed. However, a negative test cannot rule out rabies. Similarly, presence of specific antibodies in CSF or serum of a previously unvaccinated person is diagnostic of rabies. But in individuals who have a history of previous vaccination, paired samples have to be tested to demonstrate a 4-fold or higher rise in titers to confirm rabies. For post-mortem confirmation of rabies, brain sample is desirable since antigen detection by the fluorescent antibody test or FAT is the gold standard. Brain tissue can be obtained by craniotomy or opening of the skull following consent for autopsy. Whenever this is not possible, brain tissue can also be obtained by other methods, that is through suboccipital cisternal puncture or through the retroorbital or transnasal routes. A positive FAT test confirms a diagnosis of rabies and a negative test rules out rabies. DRIT or RT-PCR can also be used where FAT cannot be performed. In cases where brain tissue is not available, samples such as the nuchal skin biopsy or CSF collected post-mortem can be tested. However, while a positive test can confirm rabies, a negative test cannot rule out diagnosis of rabies using these samples. There are several challenges that we face in human rabies diagnosis. Collecting post-mortem brain tissue for the gold standard antigen detection by FAT remains a challenge due to several factors. Sensitivity of diagnosis using other samples is low, and multiple tests on several clinical samples are required to confirm diagnosis. Also, as I mentioned earlier, tests on samples collected antemortem can rule in rabies, but they cannot rule out rabies. Additionally, there are few laboratory facilities for antemortem diagnosis which are available in rabies endemic areas, and most of them are limited to referral laboratories. The control and elimination of rabies requires effective surveillance, which is the continuous systematic collection and dissemination of health information. Basically intended to demonstrate the presence and distribution of disease, inform public health policies, track the impact of interventions and progress towards specific goals, and ultimately to document the absence of disease. Poor or inaccurate data underestimate the true burden of rabies and negate the advocacy efforts needed to achieve rabies control. For the purpose of surveillance, it is important to formulate standard case definitions based on international guidelines, and these should be disseminated widely by national health authorities. Effective surveillance includes several vital elements. First and foremost, the disease must be made legally notifiable, and healthcare workers must be trained in surveillance methods and identification of cases. Community engagement plays a crucial role as well. Since laboratory testing has a significant contribution in surveillance and enhanced case detection, strengthening of laboratory capabilities to meet the needs of the country is essential. Intersectoral coordination based on One Health and building robust networks for effective communication of data is important. Also, long-term commitment and engagement of all stakeholders is essential for sustained surveillance measures. Surveillance guidelines and standards such as the Rabies Surveillance Blueprint and the stepwise approach to rabies elimination tool, which describes 5 stages of measurable progress towards rabies control, are available. Integrated Bite Case Management or IBCM involving both human and animal components can improve the overall quality of surveillance and is being dealt by other speakers. Coming to case management in human rabies, currently there is no proven efficacious treatment for rabies. And with the onset of symptoms, death is almost inevitable. Therefore, treatment is mainly palliative to ensure compassionate care and reduce the suffering of both the patient and the caregivers. This can be done with limited equipment and drugs in a hospital or even at home. Aggressive management, which includes critical care and or ethically approved experimental protocols, can be considered in exceptional cases, subject to availability of dedicated hospitals for this purpose. Factors which favor initiation of aggressive management include young age, early stages of illness, 1 or more doses of rabies vaccine administered prior to the onset of clinical symptoms, presence of neutralizing antibodies in serum and or CSF, and diagnostic tests which are negative for rabies virus antigen and rabies viral nucleic acid. Family members of the patient must be made aware of the high risk of failure and the possibility of survival with severe neurological sequelae wherever aggressive management is considered. In the absence of effective treatment options for rabies, the focus should be on prevention of rabies. Thank you.
Thank you, Dr. Rita, for the very interesting presentation on how to diagnose human rabies cases and case management. It looks like Rita is not signing, so the audience will share the response through the mail and we will upload to the OIE websites, OIE, WHO, and FAO websites. Over to you, Alessandro.
Thank you, Tenzin. I'm pleased to introduce next speaker, Dr. Claude Sabeta. Dr. Sabeta is currently a research team manager for public health and zoonosis on the Deport Veterinary Institute, OIE reference laboratory in South Africa. He has been involved in training of regional rabies diagnostics through exchange visits and twinning projects, coordinating proficiency tests and harmonizing of specific diagnostic test methods through partnership with local and international collaborators. Dr. Sabeta is an extraordinary lecturer in the Department of Veterinary Tropical Disease, University of Pretoria, and serves as an external collaborator of the OIE Pathogen Genomic Platform project. His presentation focuses on rabies diagnostic techniques and surveillance in animals. Over to you, Dr. Sabet.
Good afternoon, colleagues. I'm indeed honored to present to you during this OIE rabies webinar. Today, I'll present on the various methods for rabies diagnosis and their use in the surveillance of animal rabies. My presentation will include global rabies burden. I'll describe the composition of the Felisza virus genus, then focus on rabies testing as performed in South Africa and the regional member countries. I will then touch on specimen submissions from the field to laboratory facilities where the tests are conducted. I'll talk briefly about the methods in use as well as backup methods available. I will then provide data on rabies diagnostic tests done at Ondesteput in 2018, then conclude with a discussion on advantages and disadvantages of the methods available. As we are all aware, rabies is a neglected disease and has been known to mankind for thousands of years. The greatest burden of rabies is felt in Asia and Africa. Today, it is estimated that at least 60,000 human deaths occur annually the world over, with India contributing a third of those human deaths. There is, however, the problem of underreporting of the disease, emanating from the lack of laboratory capacity, lack of qualified personnel, as well as appropriate medical and veterinary infrastructure. Lissa viruses have been subdivided into phylogroups on the basis of genetic distances within their G protein ectodomain regions, as well as serologic cross-reactivities. Phylogroup 1 comprises the majority of Lissa viruses, including rabies virus. Phylogroup 2 on the slide, shown in green, is composed exclusively of Lissa viruses of African origin. West Caucasian bird virus and 2 other Lissa viruses form a third phylogroup. These do not cross-react serologically with any members of phylogroup 1 and 2. In South Africa, animal rabies diagnosis is performed at the OIE Reference Laboratory at Ondesteput and at the Allerton Provincial Laboratory in Pietermaritzburg, KwaZulu-Natal. Formalinized samples or specimens are tested at the pathology department of the University of Pretoria. However, human specimens are tested at the National Institute of Communicable Disease, a WHO reference laboratory. Specimens are submitted from the field by state veterinarians, animal health technicians, and at times by the public. The specimens are submitted as carcasses, at times decomposed, or in glycerol saline preservative. Some specimens are submitted as fresh tissues. This slide shows rabies diagnosticians at work. They are processing rabies specimens for testing. On the left, you can see a technician at Lanavet in Cameroon, and on the right, a technician at Ondesteput preparing for the rabies testing. The direct fluorescent antibody test, or DFA, and the direct rapid immunohistochemistry test, or DRIT, are 2 primary methods for rabies diagnosis, in line with OIE and WHO approvals and recommendations. Briefly, the testing involves making a composite smear of test samples, a positive control and negative control on a glass slide. These are then fixed in cold acetone and stained with a biological conjugate prior to viewing the slides under UV fluorescence for the DFA and the light microscope for DRIT. Under microscopy, presence of stained antigen is demonstrates a positive result. On the far right, you can see green fluorescing particles as evidence of presence of Lissa virus antigen in the sample in almost 100% of the field. On the left, you'll observe slides prepared using the DFA. However, an extra step was included to counterstain the slides with Evans blue. The stain then provides contrast and lowers background. And as you can see, the tissue will be noticeably red. Similarly, in D-read, shown on the right, the Lissa virus antigen stain is brown particles, indicative of a positive result. In addition to the DFA and the D-read, methods that I've just covered in the previous 2 or 3 slides, there are several methods that can be used as backup for those 2. For instance, biological isolation of Lissa viruses is possible in laboratory animals, such as mice, or on a cell line, such as neuroblastoma cells. Neuroblastoma cells are highly susceptible to street viruses, such as rabies virus. Many laboratories on the continent, though, do not have cell culture facilities and therefore make use of mice. Some laboratories on the African continent have the capacity to, 1, determine the origin of rabies outbreaks, and 2, establish relationships between viruses. Research institutions in particular and universities perform such tests. This slide demonstrates amplification of the nucleoprotein gene of rabies viruses, sequence of the amplicons, and establishing genetic relationships of the viruses involved. The methods that I have presented, except READSET, are commonplace in many laboratories as molecular and sequencing facilities are becoming more available on the African continent. There are also some specialized laboratories that also perform the more sensitive quantitative real-time PCR assays for rabies, but these are not many. The table shows the total number of field submissions and rabies tests done at Wondestaput in 2018. The majority of specimens are from the 9 provinces in South Africa, and in addition, some confirmatory requests from other regional countries. Overall, about 40% of the submissions were Lissa virus positive. This slide shows a breakdown of the submissions into domestic, livestock, and wildlife specimens. Dogs make the largest contribution of specimen submissions, followed by wildlife, and then livestock. This slide shows one of the potential problems that can be encountered in rabies testing, particularly when a laboratory is reliant on only one method. You can see in this slide that the 6 samples that were shown as rabies negative under the DFA were in actual fact positive with the other methods. We therefore recommend testing specimen submissions with the DFA, and in addition, use either D-read or a biological isolation method, or even a molecular assay if it's available, for continuous validation of the DFA. This slide lists the various methods for rabies testing available today. I want to take you to columns 4 and 5 that are highlighted in gray. These show that the 6 methods are appropriate for confirmation of clinical and suspect cases, and also can be useful for establishing prevalence of infection. However, MIT may not be appropriate here. This slide is a summary of the advantages and disadvantages of the 6 methods that I've just shown in the previous slide. The DFA and the DRIT are advantageous in the sense that they are rapid, they are highly sensitive and specific. In the case of the DRIT, it uses a light microscope. The disadvantage for these two is that one may require expensive reagents, for example, conjugate and the UV microscope. When you go on to the biological isolation methods, you find that these can enable propagation of the virus or pathogen, but require specialist facilities as well as operator expertise. Also, one of the problems is the long turnaround times involved, at least 5 days for RITSIT and 28 days for MIT. There are also ethical issues owing to the use of laboratory animals. Molecular assays are rapid, highly sensitive, and specific. Amplicons can be characterized, but the drawbacks include the need for specialist equipment and the potential for contamination. The importance of rabies diagnosis in relation to animal surveillance is shown here on this slide and includes the following: confirmation of suspect rabies cases, estimation of the exposure to facilitate risk analysis, and thirdly, contribution to the elimination of the disease as we are trying for rabies. I'd like to thank you, colleagues, for listening to my presentation.
Good.
Thank you very much, Dr. Saavedra, for this very good overview of diagnostic techniques that I've seen already encourage people to exchange some questions in the chat. Someone mentioned the availability of rapid tests, but I also know that this part will be addressed in the next presentation. So I have the pleasure now to introduce Dr. Konrad Fröhling. Dr. Konrad is a veterinarian specialized in virology and currently works at FLI Germany, OI reference laboratory for rabies. He has been working on rabies at FLI since 2005, first as part of PhD thesis, then gave permanent position. He is interested in rabies prevention, but rabies epidemiology, pathogeneity, and animal models. He provides technical support for the OI FLI rabies laboratory twinning project in Namibia. He will talk about OI twinning for rabies diagnostic capacity and surveillance in Africa. Thank you. The floor is yours, Dr. Fröhling.
Good morning, ladies and gentlemen. Thank you for giving me the opportunity to introduce you to the OIE laboratory twinning project between the FLI and CVL. My name is Konrad Fröhling, and I'm talking on behalf of all colleagues involved, mainly Thomas Müller, the head of the laboratory here, and Jolandi van der Westerhuizen, who's responsible for rabies testing in the laboratory in Windhoek, Namibia. So the twinning concept was first established in 2006, and an OIE reference laboratory or reference center is partnering with a candidate laboratory on a certain subject. And this collaboration has benefits for all parties involved. Obviously, the candidate lab can improve the laboratory performance and establishes international connections, whereas the OIE as a global organization improves the capacity for disease detection, prevention, and control, and the parent lab can establish joint research projects and has access to certain strains and samples, and can also establish a laboratory network. The laboratory twinning is a very successful tool of the OIE, and 62 projects have finished and 28 projects are ongoing. There have been 2 finished rabies projects. One was that we had with Turkey, and there are 4 ongoing, and one is us partnering with Namibia. So the OIE twinning project between FLI and CVL started in 2019, and the time frame is 3 years until 2021. The FLI is a federal research institute for animal health. The headquarters is at the Isle of Reims in the Baltic Sea, and specifically for rabies, we are an OIE reference laboratory for rabies and also a WHO collaborating center for rabies surveillance and research. The candidate laboratory is the Central Veterinary Laboratory located in the center of Windhoek, Namibia, and the head of the laboratory is Dr. Siegfried Kaiseb. As you can see from this work plan, I will not go into details. We have a very tight work plan and schedule, but obviously this was skewed by the COVID-19. So we agreed that the following points should be outputs of this twinning project. So first and foremost, the diagnostic capacities and capabilities of the CVL to meet OIE standards is enhanced. Obviously, the CVL already has a very high standard thanks to also the cooperation with the Ondersteport Veterinary Laboratory led by Claude Sabeta in the SADC region, but we can complement each other. Then quality control measures are improved, the role and responsibility is strengthened. We want to introduce molecular epidemiological tools for rabies surveillance and control. And last but not least, we want to establish joint research projects. I will go into detail with some of the points outlined here and explain what we have achieved so far. So when it comes to the diagnostic capacities, we have updated and significantly shortened the standard operating procedures for the diagnostic techniques. We also did the comparison of results for samples. So the samples were shipped to FLI, and we tested them with all our diagnostic tests, and we compared the results and discussed the reasons for discordant results, and we also had workshops where we trained and discussed. So these workshops were at CVL in 2019 and 2020, and also CVL staff was here at the FLI, and there was one international workshop planned under the leadership of CVL for colleagues from neighboring Angola and Botswana, but that was delayed because of COVID-19. This is another picture from the training activities. So when it comes to the epidemiological tools, the molecular tools, we're finalizing molecular epidemiological studies on the phylogeny of rabies virus in Namibia using full genome sequences, and this is just a brief image saying that most of the dog rabies cases in the north are coming actually from the dog strain, but individual cases may also be coming from the wildlife reservoir. Another joint project that we've been planning is a field trial on the suitability and of oral rabies vaccination of dogs as a complementary measure to parenteral mess dog vaccination. And what you see here is a simplified sampling kit. So we want to improve the surveillance by providing the local veterinary authority with a sampling kit. And you see here to the right, there's a plastic bag, and then obviously personal protective wear, gloves have to be worn, and people involved in taking the sample, they all have to be vaccinated against rabies as a precautionary measure. Then you take a syringe and use the under pressure of that syringe, so that the first bit of the syringe is cut, and with this under pressure you get brain material from the brain stem and those parts of the brain that would be sufficient for rabies diagnosis, and then you squeeze it into the little vial, and by doing so you avoid contamination of anything outside. It's a very clean method to get brain material for surveillance. So that improves surveillance because by doing so the field technician do not have to ship the head of the animal around, but can use the small vial and ship it to the laboratory. So the lid is closed, and then it goes into the bag. It's sealed, and then you discard the gloves. And this technique can also be used for lateral flow devices that you can also see this little picture here. I will go into detail now. So these lateral flow devices, they are similar to pregnancy tests. I will, because of the time, I will not go into detail, but first of all you have to do a brain homogenate, and you put it onto this little hole, and then this fluid is migrating on this membrane. And when you see two line, a test line and a control line, you see that this sample is positive. It is very easy and quick, so the results are obtained 10 minutes after you applied the test, and the price is not cheap. It is between $4 and $15 US, but it has certain advantages in the field, and that's what we also see. But we did do some comparative analysis. We ran commercially available lateral flow devices. There are several on the market, and ran them side by side to real-time PCR and conventional fluorescence antibody test, the FAT, and we had very unsatisfactory results for most of the samples. But there are numerous studies that have indicated that at least the antigen bionode test is fit for purpose, and that is the only test that is sufficiently tested with good result characteristic. But even with this test kit, we have seen batch-to-batch variation. So my plea to you is, do not use any other test kit as of now. Don't go into the internet and buy anything that is cheap. Please trust us. Only the antigen bionode test as of now you can use. So we also did this comparison in Namibia as part of our proposal, and thus far we've tested roughly 150 samples and had a very high sensitivity of 92% and a specificity of 100% with this test kit. And with this, I would like to thank you for your audience, and I would like to thank all of the people involved in making this possible, from Namibia, from the OIE, from our ministry, and from the FLI. Thank you for listening, and I'm happy to take any questions.
Thank you very much, Dr. Froeling, for this interesting presentation and for sharing with us the activities you have done with Namibia. within the framework of the OIE twinings and the information about the rabies test. I have a question because you did this twinning with Namibia, so I wonder if you have any plan now to support other labs in the region for this issue, and how do you see, let's say, the rabies, the rapid test within the framework of surveillance for rabies, maybe in poor setting resources? This is a couple of questions, and I invite the participants to raise questions in the chat, so we can also the speaker can also answer later. Thank you.
Okay, can I answer your first question? The first question was about how do we expand our activities to other African countries? And our approach is that we first of all train the Namibian colleagues, and as I stated in my presentation, so the Namibian colleagues will become a center of expertise. That is our idea, so that they can spread their expertise and in diagnostics, etc., to the surrounding countries. So it's not feasible for us as an OIE center, nor for Claude Sabeta to cover all of Africa and their demands of training. So we need to expand our capacities to train people, and we need to involve also other OIE reference laboratories in this task to train. And because of changing staff, this training is probably an ongoing thing. So that's the first question. Second question is the use of the lateral flow devices. Obviously, this has to be integrated in a surveillance scheme, and there's always the difficulties that these pests may produce false negative results. So there is a caution when it comes to animals that have bitten a human patient, and the application of a PEP depends on the result of this test. So if there wouldn't be any testing at all, you can use the lateral flow device as the best option if you don't have any other options. But if you have laboratory capacity, you can always, and you have easy logistics to ship your samples to the central laboratory, you should do that. And at the first step, when you want to use the lateral flow devices, I would recommend that you do it side by side to the standard OIE recommended tests.
Thank you very much, Dr. Conrad. Very clear your answer. And I think this session put at the center the importance of the laboratory in the rabies surveillance for eliminating rabies. Now I pass the floor to Tenzin for if he has other questions.
Okay, thank you. My question is to Dr. Claude Sabita. I think Sabita is online. As an OIE reference laboratory for rabies in Africa region, what do you think is the status of rabies diagnostic and surveillance facilities and capacities in the region? And what are your institute plans for building rabies diagnostic and surveillance capacity in the next few years? And also, with the current COVID pandemic still not over, do you also have a plan for conducting some sort of virtual laboratory training to the African colleagues? Claude Sabita, is your mute? Yeah.
Can you just repeat these questions? I didn't get them correctly.
Okay. My question is like, as on the spot is an OIE reference laboratory for rabies in Africa region. And what do you think is the status of rabies diagnostic capacities and facilities in the African countries? And what are your institute plan for building capacities in the region in the next few year time? And other question is, with the current COVID-19 pandemic still continuing, do you also have any plan for conducting virtual meetings, like through Zoom meeting to the laboratory colleagues in the region?
Thank you for those questions. If I may start with your first question on status of rabies diagnostic capacity.
You may
I can
also share
attest.
your video actually.
Sorry?
You may,
Should I
I think, on your video to the colleagues who wanted to see you.
What should I do? What should I do?
Okay, you can go on.
Okay. All right. So for the first question on the status of rabies diagnostic capacity, I can attest that I'll say probably more than 80% of the countries, member states, can conduct the primary method of diagnostics, which is the DFA. And also, they can also do the backup test, MIT, that is biological isolation of viruses in mice. However, I think probably 50% that can also do molecular testing. But I think we just need to harmonize and standardize some of these protocols. In case of the DREAD, I may stand corrected, but I know the Global Alliance for Rabies Control has done a tremendous amount of training for some laboratories. So I think we are well geared. We just need to do more of the proficiency testing and exchange of samples to see whether we are really getting these results correctly. And in terms of building capacity, I think as an OIE reference lab, we had a twinning project with NIVRI in Nigeria about 10 years ago. And the idea is that once we have built that capacity in that part of the continent, they can also continue. We have also trained some students. I'm saying, unfortunately, most of these are from Nigeria, so they can now do all these techniques in terms of the classical methods as well as the molecular assays. If I may also point out that we're in the process of setting up a twinning project with NADIC in Ethiopia so that we can extend the capacity to that part of the continent. But coming back to one of the questions that was asked to Conrad Froling, the previous presenter, I think as an OIE network, not only UNDESEPUT, we can involve other members of the global OIE rabies network to assist us in building capacity on the continent.
Okay, thank you very much for your comprehensive response. Thank you. Now, can Alessandra summarize today's webinar?
Yes, Tenzin. I think we come to the end. It was very, very good, and I'm going to close. Dear participants and the speakers, thank you, along with my colleague Tenzin. I would like to thank you very much for your participation in this webinar, and a special thanks to the presenters for their very interesting presentation. And we think that has been a fruitful meeting. It was we shared interesting information, and it was a good discussion. It is important, we think it is important to continue sharing activities about rabies and any new information that will come up that will certainly help moving towards the objective of reaching at zero human rabies deaths due to dog-mediated cases by 2030. So it is also important to continue sharing project activities. You have seen that we share the contacts and you have mail of all participants. So we really encourage you to keep in contact and to continue sharing. If you have additional questions or to ask, please do not hesitate to contact each other. And as you know, there will be another webinar session this afternoon at 14 GMT in French language. There will be, so I encourage you to to participate as well. If you can, there will be different presentation from French-speaking countries and other partners. Tomorrow we will have another sessions in English at the same time with updates from the tripartite and partners and rabies vaccination, surveillance and planning tools. So we also encourage you to attend the webinar tomorrow. So I think that's it. Tenzin, if you have some more, otherwise we can close the webinar here and looking forward to seeing you soon in person. Thank you very much. Tenzin, if you have some.
Thank you very much. I don't have much. Thank you.
Thank you.
Thank you.
Thank you.
Thank you. Thank you. Thank you.
Bye-bye.
Let us meet.
Thank you.
Thank you. Bye-bye.
Thank you. Bye-bye.
Bye-bye.
Thank you.
Thank you very much. Very good.
Bye. Tenzin and everybody.
Yeah.
Thank you and bye.
Thank you and bye.
Thank you.
It looks like I just managed to connect just to say bye, everybody.
Yeah,
Thanks,
bye.
Thanks much. welcome to the end of the program. Thanks much.
Motepele, how are you? Motepele.
Yes, Sam.
Yes.
How are you?
I'm very fine.
Habari za siku mingi.
Nzuri sana. Habari ya huko kwenu?
Tuko tu.
Habari.
Naona ujoto iko mbaya sana.
Ambia Motepele ajifunze Kiswahili.
How are you, Sam?
Dr. Tenzin, how are you?
Yeah, I'm fine.
Yeah.
Thank you.
Tenzin for good work.
So you managed to.
And Patrick and Alessandro, good.
Yeah,
Yes.
this was very good, guys.
Oh, thank you very much. We'll meet tomorrow then.
Yes.
Yeah, we'll meet tomorrow at the same time, 12 o'clock.
Okay.
Thank you.
Good night.
Tomorrow.
Maybe let's Bas, Alessandro, Sam, we can discuss something after this.
Sorry, Tenzin, you are saying something?
We can discuss about the today's webinar, how it went and what to be corrected.
Hello?
Yes, hi.
Tenzin, I have to leave now for another meeting.
Okay.
So go ahead, and my feeling is it was very, very well done.
Okay.
Yeah,
Thanks.
I'm personally very, very happy. Excellent to the entire team. Excellent. We'll see you tomorrow. All the best. Let's.
Yeah.
I saw your message, and I really concur with your feeling.
Yeah. No, it was excellent. Thank you very much.
All the best. Thank you.
Thank you. Bye.